I want to start by welcoming everybody. In fact, on behalf of the COBRA on Opioids and Overdose in Rhode Island, the West Virginia Clinical and Translational Science Institute, the West Virginia IDEA Network of Biomedical Research Excellence, the Rural Drug Addiction Research COBRA here in Nebraska, and the Center for Addiction and Disease Risk Exacerbation at Brown University in Rhode Island. We would like to welcome you to the 2023 Symposium on Substance Use Research. And yes, I did use the teleprompter for that statement. I intended to memorize it, but didn't get a chance to. And actually, this is a bittersweet welcome because we have entered our last panel discussion for the symposium and our last activity for the symposium. But what a great way to end, as we'll see here over the next few minutes. Start by introducing myself. My name is Alex Mason, and I'm a professor in the Department of Child, Youth, and Family Studies and in the Nebraska Center for Research on Children, Youth, Families, and Schools at the University of Nebraska-Lincoln, with an affiliation with the Radar Center here. And I just wanted to pass along a few reminders, kind of logistics, before we get into the meat of our discussion. And if you've been joining the discussions, you've heard this, but it's a good reminder. This session is being recorded, and the recording will be distributed to our distribution lists and posted on the website so that others can benefit from the discussion and the content at later times. All attendees are currently muted, but we do encourage questions, and you can use the Q&A function in Zoom to submit questions. And please feel free to do that at any point in time. We will be sure to dedicate some time toward the end of the panel for a Q&A. But again, you don't have to necessarily wait for your questions to that point. You can submit them as they come to mind. I personally think we have a very exciting session to close out the symposium for you this afternoon on a really critically important topic in what is a vibrant area of research and practice. And of course, the title of our session is ACEs, or Adverse Childhood Experiences, Stress, Trauma, and Substance Use. And it's easy to see that we have a lot of stress and trauma in the world these days, with significant implications, as we know, for substance misuse in different populations. And so we'll get a chance to talk about that a bit, what we've learned and where we're headed and how we can apply the information that we've learned. And we're very fortunate to have an esteemed group of panelists to guide the discussion today. So please join me in warmly welcoming, and I'm just going in the order on the agenda, Dr. Leslie Cottrell, Dr. Adriana Espinosa, and Dr. Frankie Tack. And so I'll give each a chance to introduce themselves, just position and affiliation, and then research and practice interests in this space of stress and trauma and substance misuse. I'll start by elaborating briefly on my own interests. As mentioned, I'm at the University of Nebraska-Lincoln, and I have a research agenda that focuses on child and adolescent development, both problem and positive development, as it relates to the onset and progression of substance misuse and co-occurring problems, and the translation of that knowledge into the development, implementation, and evaluation of preventive interventions, primarily school and family-based prevention programs. So how about just some introductions from our panelists, which is the most important thing. And so Leslie, would you mind starting?
Sure, I definitely won't mind. Hello, everyone. My name's Leslie Cottrell, and I'm a professor in pediatrics. My background's in developmental psychology. I'm also the director at West Virginia University Center for Excellence in Disabilities. So my focus today in particular is on two populations, one being individuals with disabilities. We know that substance use, stress, trauma can impact individuals with disabilities, traumatic brain injuries, across the gamut a little differently. So hopefully we can talk about that. And then women who have or use substances and have a small child who might be diagnosed with neonatal abstinence syndrome and or exposed in utero. Thank you.
Thank you. How about Adriana?
Sure. Hi, everyone. Adriana Espinosa. I am Associate Professor in the Department of Psychology at the City College of New York and doctoral faculty of the Graduate Center at CUNY. My research is focuses on the understanding of all the life course factors that influence substance use in adulthood. But when I look at in my research, I mostly focus on the early childhood experiences as precursors of the path to substance use. And I like to look in particular at issues among minoritized populations, but there's always something that I don't ignore, which is the intersectionality with other aspects, including sexual identity and including issues with disability as well.
Great, thank you. And Frankie.
Hi, my name's Frankie Tack. I'm Service Associate Professor at WVU, and I coordinate our mental health and addiction studies undergraduate program and the associated minors with that. My background is clinical, and so I am involved in some research efforts, but more from an applied standpoint. My clinical background was in perinatal maternal and women-specific treatment, and that continues to be an interest for me. I also have some interest in tobacco use disorder and minority stress models relative to LGBTQ population. My biggest current project right now, Project Train, is an interdisciplinary project where we're working to provide, based on some research we did in the state several years ago, training to K-12 teachers and how to work with children who live in homes with addiction, and the behaviors and adaptations they bring with them to the classroom. Other than that, I'm on a sort of an odd thing that's kind of a little bit out of my scope, but I'm enjoying it, a project working, it's actually with the NIDA node folks in our area on the impacts of occupational therapy on methamphetamine use disorder. So that's kind of an interesting little rabbit hole I've run down. So I'm glad to be here.
That's great. Sounds great. Those rabbit holes can be a lot of fun and interesting, especially with good colleagues, right? Well, thank you all for those introductions and especially for your time and expertise today. I think everybody in attendance can hear already that we have just a great panel with a breadth of research topics, population studied, both research and practice. And I just think it's a really rich way to dive into a rich and challenging and important topic like what we're talking about. So we have started by identifying about 3 questions that we've pre-selected to discuss. We had the chance to touch base on that. And so I'm going to start by going through those questions. I think they will generate an intriguing and useful discussion. We'll see how that goes. And then again, welcome questions using the Q&A function as we go along. And I really like this first question because we got to thinking as we were planning for this that there's a fundamental set of questions that we often overlook when we start discussions like this, and yet they're critically important for how we approach these topics and these questions. And so this is the question that we'll start with. What are important considerations in the definitions and measurement of substance misuse, as well as ACEs, stress, and trauma in this area of research? And as mentioned, we often just, jump right to, well, what do we know or what can we do with it? But these are really complex constructs and ideas. And just to kick it off, I'll mention when we, had our initial discussion, particularly from a child and adolescent development perspective, I've tended to think of the term substance misuse, for example, as kind of an umbrella term that captures any substance use, even if it's a legal substance, for underage individuals, as well as, of course, risky or problematic patterns of substance use leading up to and including substance use disorders potentially. So, that is a very broad umbrella way of thinking about that term, but it's not very sensitive to practice perspectives and considerations and distinctions of substance use disorders, for example. And so I think it's just worth taking a little bit of time, especially as we start to grapple with this a little bit more. So I'll stop talking and just would love to hear from our panelists on this important definitional issue.
Alex, I think you hit it right on the head in terms of the use of the term misuse, particularly for individuals with disabilities, where their treatment regimen includes opioids, might include other substances that we're tracking. And what we hear through the center is that everything from the management of their medications to the interpretation of side effects, is it from their disability, is it from the medication, where's it coming from, is confusing to them. It's often confusing to providers, and makes it difficult to identify next steps. So I appreciate you saying that.
Yeah, no.
And I think, from a general umbrella term, we've struggled in our profession because we're trying to let go of stigmatizing language. So we took that A word out and we've substituted it with misuse, which I think, just generally speaking, isn't a problem, but I think it can become a problem when you move into the research arena, because what you just described was everything from a young person using a substance, maybe not even so-called overusing it, but it's high risk because of their age, all the way up to someone with a substance use disorder. And so that is, the interventions along that continuum are very broad. We understand misuse clinically is that idea of overuse that's infrequent, with maybe some consequences, but not escalating compulsive, repetitive consequences, or using prescriptions, over-the-counter medications not as prescribed or not prescribed or indicated for you. And so it has its own definition. And I think where we get into trouble, or the risk is with research, is that we don't operationalize the definition of who we're really trying to study and what we're really trying to study there, because that population is very different from someone who has a substance use disorder. And even within substance use disorder, we have a challenge of the word addiction, because our diagnostic manual is silent on what addiction is. I operationally think of that more as moderate to severe, and that so we've got that severity indicator, but a mild SUD looks very different than a moderate to severe, and our interventions and treatment plans tend to be different. So again, when we mash all that together, we really risk confounding our research results. And even young people like who you work with, Alex, can have substance use disorders, moderate to severe substance use disorders.
Yeah. Yeah, absolutely.
So similarly, I agree that there's a need to hone in on exactly what are we talking about when it comes to the issue at hand, the problem. Is it the use? Is it trying? Right? We sometimes conflate trying substances or trying tobacco or alcohol with use. Particularly in the research, which is a big leap in logic, assuming that those who try will end up using, will end up dependent. So we need to definitely be more careful when we look at these contexts or these concepts, because the intervention will depend on the definition that we are attributing to it. And similarly, when it comes to looking at adverse childhood experiences or these ACEs, we need to think about broader conceptualizations of ACEs as they exist now. The ACEs questionnaire is limited in the sense that, well, it was relevant at the time it was created, but today's society is very different than the society then. For example, our children are now exposed to incredible higher likelihood of gun violence in the schools, in their neighborhoods, everywhere. Gun violence is nowhere in this, and which is an incredibly traumatic experience. It's nowhere near in the ACEs questionnaire that we tend to look at. So from a research perspective, we need to think of adverse childhood experiences beyond what is captured in a lot of the existing measures. And those additions need to also be more relevant for the populations that we're studying. Like, for example, children of immigrant parents or immigrant children, they themselves go through additional stressors that are not necessarily relevant for other populations. So when we're thinking about examining these concepts, we need to think about the population that we're studying and really just operationalize the issue or the concept to their world, to what they're experiencing.
I'd throw into that too, relative to ACEs. And Adriana mentioned it, you know, she and I have some similar interests here, that, you know, minority stress broadly, but when you look at particular populations, some populations have extremely are at risk in their own communities, like trans people, for instance. And so, you know, taking into account appropriate minority stress models as an adjunct to traditional ACEs as well, I think is very helpful. I'm going to actually drop a link into the latest and greatest LGBTQ minority stress model, the latest one I found from, I think, about 2 years ago. It's really excellent. And when you look at all the specifics that are in there, you begin to realize what a hole there is in the ACEs potentially for some of our participants.
Yeah, that's great. Thank you for that link, Frankie. These are excellent points. There's a tremendous amount of nuance here that we often don't grapple with or haven't adequately so, based upon developmental period, population, you know, structural context, and among many other considerations. And what's nice about the points that are coming out here, take, for example, you know, returning to the substance misuse discussion, you know, the idea that, I mean, these are distinct behaviors. And as we've mentioned here, they require different prevention and treatment intervention strategies. And that is true because they have a different etiological pathway often. So there's different sets of risk and protective factors and processes for initiation in early adolescence compared to, you know, risky drinking in young adulthood or substance use disorder, you know, at another time period, let alone across different populations and minoritized populations especially. So and then, you know, another thing that we touched on in our planning discussion that I thought was valuable in regard to ACEs, not only, you know, have we been sort of constrained by this particular definition for many years now, right? And there's the potential to expand that or tailor it. But then the classic way of operationalizing ACEs is as a count of the number of experiences. So I wonder if the panelists have thoughts or comments about that.
Many
Many.
thoughts. We are so bounded by the idea of adding symptoms and adding items from a questionnaire for the purposes of research that we really miss the qualitative component of what these experiences say. individually about health and the individual, going forward and their likelihood of becoming dependent. We assume, in adding all of these items, we really assume that they are all equally weighted. And take, for example, somebody that has an ACE score of 4 versus an ACE score of 2. We think, oh my God, you have high ACEs if you're 4. Well, let's see what those 4 ACEs are relative to the 2, right? There are differences in the types of these experiences, and how these experiences affect the individual will vary depending on how severe they are. And that is not something that is truly captured by this process of just adding up. So I think we need to take a step back and think about the qualitative differences that exist between these experiences and how they individually or separately say something about the stress and the individual's likelihood for substance use, because that's, again, where the intervention would come for treating the trauma associated with the experience.
I agree. I've always wished the ACEs had a severity index, and the example I like is, the divorce. Well, you can have a very amicable divorce, and that's still going to create some challenges for a young person, but you can also have a very, very awful, horrible, extended divorce with lots of false accusations and, drama, high intensity emotions and things that can be very, very detrimental. So I'm completely with Adriana on that, and frequency as well. I mean, I think, there's an assumption of chronicity kind of in the ACEs, but for the ability to step back and look at, okay, how bad was it and how frequent, because if it happened repeatedly and it was fairly mild, that could create its own trauma, where there, for some things, a one-time event such as child sexual abuse could be horrific.
And I think that's a really good point in terms of the impact of the trauma on the individual. Did the individual understand what was going on? What were the services provided afterwards? The resolution, if the immediate resources. I think for when we were preparing for this, we were talking about when you go to apply the ACEs, you automatically start pulling in more than the ACE measure to do that, whether it's the resiliency twin for it to kind of get the other picture. But many people out in the field would say, okay, so what? They've had a divorce, they've gone through these certain types, whether it's the frequency or not, certain things. Here in the now, here's what we're seeing behavioral wise or outcome wise. What do we do with this information? I think also to have that interpretation. In addition, you're saying some of that the frequency and the effect, but the interpretation of something, bring that research into the implementation, clinically or otherwise.
Yeah, absolutely. These decisions have real implications for how we think about and these issues and how we use the information that comes from them. So which is exactly why we thought this could be such an important way to start our conversation. So thank you so much for those excellent points. Maybe I'll
Can I toss one more little?
Yeah, go ahead,
and
Francis.
just to,
Please do. Yeah.
The other thing I think you have to consider when we're, and this is back to some operationalizing the definition, is that in addition to severity specifiers on SUD, we also have remission specifiers. And I think many times you see that studies will be looking at someone who is, quote, in recovery without much attention to the length of that recovery. And sometimes you can infer it from whether they say secure their research subjects from, say, an inpatient treatment program or something of that nature, but their there are some nuances there as well that could also confound our work. And so I think using the tools, and I'm not saying the diagnostic manual is the end all be all. I know there are challenges and criticisms and limitations as well there, but it is there as a tool for us to consider as we're defining our subjects.
Yeah, definitely.
Thanks for letting me toss that in.
No problem. That's great. Appreciate that point. You're right. There are tools out there, and of course that's critically important to provide guidance in these conceptual issues. And just shifting a little bit, I mean, sometimes these terms and definitions, the measurement of them are somewhat atheoretical. I think often there's some underlying theory there, even if it goes unstated after things get a little, say, reified over time as it gets used often. But another question that we thought was just a critically important foundation is, what are some of the theoretical frameworks used to understand the interplay of ACEs, stress, trauma, and substance misuse? And maybe as panelists are answering that question, they can speak to, simultaneously, what is the current state of knowledge about support or not for those theories. And again, just to kick off a discussion, I think one of the more obvious theories that comes to mind in this area of research is the self-medication model. So experiencing stress and trauma and then using alcohol and other drugs to alleviate the stress, reduce the tension, get rid of the pain, and so on, as of course, a rather maladaptive coping strategy for handling that stress. That model's been around for a long time. There's a lot of research on it. And it's not always apparent how well supported it is at different developmental periods, at different populations, and so on. So that might be one thing to speak to, but of course, feel free to mention any other theoretical perspectives you've found valuable in your areas.
I'll jump in. I really feel like the self-medicating model, we can just start there, sort of comes out of the psychological models. And, we talk about big T and little t trauma, generating symptomatology for people that then they find temporary relief with by applying substances, either intentionally or unintentionally. Like I like to say, sometimes people bump into substances and then realize, oh, I'm getting relief from all of these trauma symptoms I had. And so it works. And I think, well, that this is more clinical, but in training young clinicians, I used to say, you can't ignore that it does work. In the short term, it works. And I mean, that's what we're fighting against. And then, but then of course, over time, it causes an exacerbation of the trauma symptoms. And so there's this vicious cycle that ensues. I mean, and then you throw into that, in addition to big T and little t trauma, with the seeking relief from symptoms of mental disorders. And again, that in the short term that does work for many people, but in the long run exacerbates them. So, I mean, I think there's a lot of validity and some research support for that. I don't think personally that it's enough, especially when it comes to youth, because we have the sociological models, which really look at all those external pressures and how they can create the vulnerabilities for substance use, which then can potentially lead to substance use disorder. Some of the things Adriana was mentioning culturally. But I will say, at the end of the day, the prevailing clinical theory, I still think, is biopsychosocial. And that is, we take each person as they come, and we do a really good assessment across the different areas of their life to then step back and say, which of the psychological or medical or sociological do we need to work with them on building their strength and resilience or around? And that could be different for different people.
I agree. We use the biopsychosocial model a lot, as well as the two-generational approach. So many times, whether it's individual with intellectual disability or you're talking about a child within the home and caregivers or grandparents are providing caregiving, and things get complicated and there's many people involved. So that assessment might also include those individuals and the things that are going on. And then lastly, we incorporate labeling theory when it comes into play with disabilities and how much an individual might buy into that to use as an explanation or support for, engaging in SUD.
Yeah, so similarly, on the biopsychosocial front, that's certainly very relevant. So it's Bronfenbrenner's ecological systems theory, which really basically says the same thing, right? It's not just the one influence. The influences come from all sorts, including policy level, including social norms. What is viewed as acceptable ways of coping with stress or with all of the aspects that are happening in your life. I've looked at the intergenerational transmission of health attitudes and also trauma, right? But more relevant to tobacco use and alcohol use as a coping mechanisms. I will do what my parents have shown me, right? That works. And I also look at a life course perspective. It's not a theoretical model per se. It's more of a framework for that is just basically saying the same thing as ecological system models, which is basically saying things happen across the life course. Early on, you may have some trauma that happens to you, but that doesn't mean that you don't have any additional trauma happening later on in life. So considering the impact of trauma across the life course, that is also going to be very informative for understanding dependence in adulthood.
Yeah, no, these are great points, how it really situates both the trauma and the substance misuse in whatever form within a broader developmental, contextual, individual and social framework. I know in the way that I describe what guides my work, I also draw on the biopsychosocial model and make it kind of a mouthful, biopsychosocial developmental contextual model, because for all the reasons that we're mentioning, and these are important points, because people aren't defined by their trauma, they're not defined by their substance misuse. There's a broader context always involved, and from my perspective, with more kind of a developmental psychology leaning, these are developmental problems, and they have roots in early child development dating back to the prenatal period, both risk and protective processes that move towards substance misuse, processes that move away from substance misuse, which obviously has implications for opportunities to intervene and redirect if needed. And so, yeah, these are.
I would also put attachment theory on our list, and I think that connects with some of the popular, literature today around recovery and addiction being a disease of disconnection. I'm not a big fan of that, because I think it boils a very complex, brain disorder down into just get a friend and you'll be fine. But I do think that if we tie it back to attachment theory, that makes a lot of sense. And again, that these are things we work on with people clinically, and understand that healthy attachment, even if you did corrective healthy attachment now, even if you didn't have it then, can support long-term recovery. So there's quite a bit of research out there on, and there are some who even think SUD could be characterized as an attachment disorder, which I find very interesting. Borani, I don't know if you're familiar with Borani, but she had done some research on and found strong correlations between insecure attachment and substance use.
Okay, yeah. And before we cycle off of this question, a couple of you have mentioned already minority stress theory, intersectionality theory. Any further comments on that and how that's being integrated these days into these broader biopsychosocial models?
I think it's has an intersectionality in particular. It's talked about, but not necessarily has been integrated as much as it should be. And it's probably because methodologically it presents a little bit of a challenge, right? How do you, I sort of interconnect all of the individuals' identities to see differences across groups in substance use. You know, what we know is who do interactions, and so those are limited. There's more advanced frameworks, statistical frameworks like latent class analysis, for example, that are now starting to be used in this context to understand how ACEs or any other stressful experience can affect the individuals differently depending on their identities. The biggest challenge that I have seen is that, first of all, you have to design a study that collects all of that information, right? You have to really be very careful and collect all of the relevant information about minoritized identities. And we, as researchers, are just learning about it. So we're not necessarily, you know, we're still the learning is still happening. The alternative would be to use existing data, population-based studies, to run some analyses, but then those are limited in what the information that they can provide about race, ethnicity, about sexual orientation, gender identity. They are just, the information is just missing. So we have the idea of intersectionality. It's an incredibly important framework to consider, but I don't think that the state of the science is yet ready to look at those questions as they should be looked at. But the more that we raise this as an issue, raise awareness about it, the more influence we're going to have with those big population-based studies that could provide us with a lot of information to look at the intersection of multiple identities.
Excellent. Yeah, good points. And some real gaps there to be filled in the coming years. I'm monitoring the time here. I don't see any questions submitted yet. So just a reminder to those in attendance, feel free to pop some questions in there. How about we turn to what is our final pre-selected question? And we've been touching on this a little bit already, but this will be our chance to really consolidate, I think, some themes. This third question is, what are some of the most urgent policy, prevention, and intervention implications based on the main findings of the ACEs stress trauma literature to date? And again, you know, feel free to reinforce any points that have been made already, or pursue some new avenues maybe that haven't come out of this discussion yet.
I'll start. For individuals with disabilities, I think one of the urgent needs remains to be detangling these from one another. So disability is not trauma. Trauma is not disability. How they intersect is an important feature that we're still grappling with. And in the literature, it's still confusing, as well as how to approach it clinically, and what guidelines we provide. So that's one area for that population I would list.
Leslie, can I ask you a question about that?
Sure.
Is there, so is there any measure of disability trauma? Because for some people, disability is the result of a trauma, or much like minority stress, I would guess there is disability stress, and which could also be traumatic. Are there any like measurement instruments on any of that?
So you can find, there are here and there. There's not one consistent scale that's or measure that's commonly used that I know of, but maybe someone on here could share that if they do. But many people are trying to find that in an attempt to sort that out.
So one of the things I would like to see really is a big shift in the school systems, how we talk about and deal with children who are traumatized. Trauma manifests for children manifests into maladaptive behaviors. We know that. The school system is highly punitive with our children, in particular children who are minoritized ethnically or who have a disability. Those have been known, and the Department of Education came out with a report indicating that those are the children who have the most severe consequences in the schools because of their behaviors. But their behaviors are a result of trauma or their disability. And so, but the school system, their policies are so highly punitive that what happens is they end up traumatizing the child or stigmatizing them even further by maybe suspending them or even expelling, or just taking them out of the classroom, demonstrating to other children, well, this individual doesn't belong here because they're different or they can't adjust to our rules. And so I would like to see a big shift in those policies and in how we, the schools deal with that, because the children, the children who maybe have trauma or they have disabilities of some type, autism or any kind of social difficulties, then oftentimes get even more traumatized in the schools.
Yeah.
And I'd even add to that children who are living in homes with addiction can be the recipient of stigma that's actually aimed at their parents,
Yes.
at the caregiver with addiction. And this is part of what we're doing with our K-12 teachers here in our training, is we have a big focus on stigma, because if you're talking negatively about the caregiver who has addiction, the child is getting the brunt of that just as much or more perhaps than the adult would, and as well as being bystanders, teaching teachers not to be bystanders when children do that with each other or when they hear other people in the school doing it. And so again, language matters. We know this. Language matters and attitudes matter, and we don't want to contribute to the trauma that living in an addictive home already has.
So Frankie, in your program, I've heard from teachers that they're overwhelmed. Not to stray too far, but in your program, do you think that they focus on the behaviors or the etiology of the behavior? And is it, as we move in, right, if we go to address what Adriana was saying, what's our role? What are we trying to shift in their resources, in their point of view?
Yes, well, the approach we've taken is to give them sort of Addiction 101, helping them really understand what addiction is and what it isn't. We've taught them about the family systems model. We're teaching them family systems and how addiction impacts upon the family system, and therefore, of course, the children in the home, and that children don't leave their behaviors inside or their experiences inside their home when they come to school. They bring their whole self, including all their trauma from living in home with addiction and all their adaptations. We focus a lot on the adaptations. We tend to think of the scapegoat. Adriana's talking about the acting out child, and particularly the more minoritized child who might get worse consequences. But there are other adaptations as well. And some of those tend to actually get positive feedback, and so in the classroom, which reinforces it. So we're providing resources and classroom resources that are age specific for different age groups of children, and we're also then we have a primary module on teacher self-care. So we're talking about professional enabling, professional boundaries. You hear the burnout from teachers because they feel helpless, they feel hopeless, and they've let themselves get over involved emotionally. And so helping them say it's okay to pull back, and here's some skills and tools you can use so you don't feel helpless and hopeless. So that's been our approach. And by the way, that was all based on the research we did. We had over 2,700 K-12 teachers in West Virginia who responded and told us what they needed. So that was all based on what they asked for.
Yeah, so to piggyback on that, we need to have a lot more socio-emotional resources for the children and for the caretakers, including the teachers. Because if we, only focus on the one avenue, which is or the children or the caregivers, we're really missing the whole point. It's a whole cycle. And I think everybody needs to be better equipped to understand emotions, trauma, and to just have a better understanding of just the differences that exist among individuals, and how those differences are not necessarily the point of for shunning them or for criticizing them, but rather it's a way of learning from each other. Just be more inclusive and more accepting. It is then when those attitudes change, beginning in the school, which is where the most of the interactions happen with our children, that's when we're going to start seeing a shift in society.
Yeah, one of the things that's been emerging in the world of prevention science, I think these points are compatible with, I found intriguing, really borrowing from the precision medicine movement. But, we've been talking about such rich nuance in the ways that trauma and substance misuse are manifest, obviously in their relationships, given the context, developmental period, populations, and so on. And it really does beg, and of course the field is moving in this direction, an increasing level of nuanced understanding on the research side of, what types of trauma for which individuals at what developmental period are related to what specific manifestations of substance misuse or transitions from one type of substance misuse to another. And the more we can develop a knowledge base that I think, moves away from the simple, this risk factor is associated with this outcome, then we can move to better tailoring in our, I'm speaking of prevention strategies, here, but obviously some relevance beyond that. But that, to me, seems like a potentially powerful way to, enhance these one-size-fits-all strategies that, especially in prevention, we've been using in recent years. Then again, that tailoring and that targeting takes tremendous care, given what we've been discussing with the stigma potential and the labeling and so on. So, some challenges still to grapple with.
And the type of early intervention when one of those types of traumas happens, that is most effective to prevent those negative ACE type outcomes long term.